It's fair to say that everyone considers themselves a rational person when looking in the mirror every so often. But you don't know what you might be capable of doing if you ever might get pushed to the brink of your mental capacity. Desperate situations have made people do desperate things, and desperate situations have made people do irrational things. Working in the emergency room myself, you would be surprised to see how many of the conditions patients present themselves with are actually self-induced. And today, we will look at such an extreme case of self-harm. Welcome back, everybody. My name is Doc Feedy. I'm a MD who likes to talk about cases and true stories, most with a medical touch, that people such as you and I have went through. If you like what I do, stick around to see more. And with that out of the way, let's dive into this case. This case takes place in Ireland, in its capital, Dublin, to be more precise. The year is 2022. A 66-year-old woman presented herself in the emergency room at St. Vincent's Hospital, seemingly open about the fact that she had swallowed, and I quote, an unknown number of cylindrical batteries. Yes, you've heard that correctly. An unknown number. When the average person thinks of self-harm, we think of cutting, burning out cigarettes on our skin, drugs, alcohol, or really any risky or dangerous behavior. But as Mahoney and colleagues, the authors of this report, state, ingestion of batteries is a rather rare method of self-harm, and not one I have personally seen. According to the National Capital Poison Center, NCPC, most of battery ingestions are of the smaller kind, with button batteries, and occur in children with access to electrical devices, such as toys or other entertainment tools. Alarmingly, the incidence and severity, including the mortality of battery ingestions, seems on the rise. Unsurprising, after all, given the rising exposure to technology in kids and the progressive automatization of our households. After hearing this rather unusual and alarming claim, doctors performed an initial abdominal X-ray of the woman, revealing a rather disturbing number of cylindrical batteries scattered throughout her entire digestive tract. And this is what it looked like. Now, calling this somewhat of a predicament is an understatement. Luckily for the patient, on the X-ray there didn't seem to be any signs of acute obstruction or perforation in the digestive tract. Neither was there structural damage to the batteries themselves. Nonetheless, there were a great number of batteries scattered throughout this woman's stomach and intestines. Batteries can not only harm the lining of the sensitive digestive tract, causing bleeding or ulcers, they could also lead to perforation, puncturing a literal hole through the mucosal wall of the digestive tract, which does not only cause air to escape into the abdominal cavity and can be seen in X-rays in such cases, but it can also cause fluids such as gastric acid, stool, and other enzymes to enter into the abdominal cavity, causing damage, inflammation, and possible infection to organs and the peritoneum lining the abdominal cavity. On the other hand, the batteries could lead to obstruction in the digestive tract, causing distension, edema, and ultimately sepsis and shock through bacteria escaping through the damaged intestinal walls. And let's not forget that the ingestion of already damaged batteries might also lead to the escape of battery acid right into the digestive tract, which can also cause severe chemical damage and burns. Lastly, as mentioned by the authors of this case report, there can also be significant changes in heart activity and rhythm disorders seen in the ECG that can be caused because of the battery's inherent voltage, although I personally consider this a rather secondary risk. So, in total, many possible complications can arise from battery ingestion. The medical professionals supervising this case were thus, from their own account, facing problems from very different angles, and they had a decision to make soon. Firstly, there are no clear SOPs, short for standard of procedures, or treatment guidelines when it comes to the ingestion of larger cylindrical batteries, rather than the button batteries previously mentioned. Secondly, the main question of the jour was, how do we get these batteries outside of this woman before something bad happens? Or do we even intervene? when it comes to dealing with ingested objects that should not belong in a human gastrointestinal tract. 3 options are possible. The choice of treatment depends on the severity of symptoms, as well as the size, number, and nature of the object or objects in question. But before we look at these treatment options, we have to get a basic structural understanding of our digestive tract at first. So, let me briefly explain. When referring to the digestive system from a functional perspective, we shall not only consider the anatomical passage that our food goes through between our mouth up until the, very end of our intestines. It also includes all of the glands involved in digestion, salivary, gastric, and intestinal, as well as the pancreas and the liver, whose enzymes and secretions not only help, but are necessary to digest our food. Beginning at mouth level, digestion already starts with the saliva. The food then passes through the pharynx, into the esophagus, and into the stomach, where the enzymatic separation of food components truly begins. We shall then move to the small intestines, where resorption of nutrients takes place. This passage constitutes of the duodenum, the jejunum, and the ileum. Finally, the large intestine's main function is the thickening of the remaining food pulp, storing undigestible food components and excreting them in controlled fashion through defecation. All of the aforementioned organs past the esophagus find themselves situated in the abdominal cavity that is lined with a membrane called the peritoneum that supports most of the abdominal organs and contains blood and lymphatic vessels, as well as nerves. This is why an inflammation or perforation of one of these abdominal organs can be so devastating, because any damage to the sensitive peritoneum can quickly spread throughout the entire abdominal cavity, leading to multi-organ failure. With this knowledge at hand, we can now better understand the 3 treatment choices the Irish doctors had when looking at this 66-year-old woman with the batteries ingested. 1. They could try a conservative approach, observing the patient, treating the slight pains involved in the passing of the object, and letting Mother Nature run its course. This would obviously eliminate all possible complications from an operation or anesthesia. But what does this conservative approach entail? Well, time. From start to finish, what is referred to as gut transit time can last between 10 to 70 hours between food intake and the defecation of that same food. A lot of possible factors play into this gut transit time, such as fiber intake, water intake, activity levels, biological sex, gastrointestinal illnesses such as diverticulitis or tumors, certain drugs, as well as individual toilet habits can all be influential, which makes this a very variable process. Here is a tale from personal experience. I remember being nervously on the ward, checking very frequently on one of my patients, a bedridden man suffering from dementia, who had unknowingly dislocated his intestinal feeding tube, or PEJ, and had somehow pushed it entirely into his small intestines. This made me sweat profusely, as did our visceral surgeons. I frequently checked the man's abdomen every shift to make sure I wouldn't overlook an abdominal obstruction. It took more than a week for him to defecate the plastic parts, and as it left his body, so did my fears. However, waiting and hoping might not be enough, especially if the swallowed objects seem to be too big to pass through, or are too numerous, or too dangerous, being too sharp, for example, in nature to risk wounding the patient from within. In this case, a second possibility in dealing with foreign objects arises. That is endoscopic extraction. Endoscopy means to literally have a look inside, using a small camera mounted on a flexible, thin tube. This can be done on both ends of the digestive tract, depending on the medical problem at hand, and is done under sedation and is usually shorter than any operation, as well as obviously less invasive and with less complications. Another quick anecdote on my side. There is a young woman who would frequently come into our ER after repeatedly swallowing sharp objects such as knives, blades, and glass in an act of self-harm due to severe borderline personality disorder. She tried swallowing an ashtray before a colleague of mine stopped her. When questioning her in a clearer moment, she said that she not only enjoyed the self-harm, but also the propofol sedation that came with every endoscopic retrieval of all of those objects. The third and last option is the most invasive: surgery. It is reserved for the most acute and severe cases of swallowing foreign objects, involving, for example, perforation, obstruction, heavy abdominal bleeding, peritonitis, or the fact that the object or objects in question are not otherwise retrievable. So, what ultimately happened to the patient in question? The Irish medical colleagues tried the conservative approach at first, something that seemed very reasonable, as the woman didn't seem to be in critical condition. Additionally, the initial X-ray didn't show any of the aforementioned red flags. So, the patient was under daily clinical observation and received weekly X-rays of her abdomen. Unfortunately, only 5 of the very numerous batteries left the woman without any further intervention over the course of 3 weeks. They were AA batteries, by the way. Additionally, the woman started to complain about abdominal pain and loss of weight. It was deemed that endoscopic retrieval would not be possible, given the number of batteries. And ultimately, the decision was made for open surgery, and a laparotomy was performed. This involves making a big median cut over the abdomen to have open access to the entire abdominal cavity, as the suffix "tomy" always means cutting. Upon looking inside the 66-year-old woman, operators were shocked. The woman's stomach was so distended from the battery ingestion that it was at the anatomical height of her bladder, at suprapubic levels. Something that could have been guessed in the initial X-ray from the position of the batteries in the middle, but one would have never guessed that the solid mass of batteries down below would be in the distended stomach and not the small intestine. This was absolutely mad. The operators then made a further incision into the stomach to retrieve the batteries, recovering a total of 46 AA and AAA batteries. Meanwhile, 4 batteries were remaining in the colon, and these were pushed through the remaining large intestine into the rectum and removed transanally with manual tools. In total, this woman had ingested 55 batteries, according to the authors of this case, Mahoney et al. This singular case seems to be the highest number of reported battery ingestion to date. And other than deliberate self-harm, the exact details of the reasons as to why the 66-year-old patient had chosen this way to hurt herself were either not reported by the authors or even unknown to them. Luckily for her, the woman made a quote-unquote uneventful recovery, as one might hope after such an eventful journey. So, this is the end of the bizarre case of extreme battery ingestion. What a ride. I hope you found this not only entertaining, but also learned a thing or two about our digestive tract. This has been, as always, Doc Feedy, and I will see you all in the next video. Stay safe out there.